Good morning. In 1992, I arrived from India to start my residency at one of the toughest training sites, Kings County Hospital in the heart of Brooklyn, New York, at the height of AIDS epidemic before we had effective antiretroviral drugs. We used to have a prison ward there at that time. As an intern, often you would be called at night to draw blood, and then I will walk in there by myself, unaccompanied by anyone else, in an open ward with 16 toughest inmates. Many of them had AIDS. I especially recall several of them joking, I hope, that they would say, "Doc, be careful. I could just stick this needle in you, and then you could have AIDS too." I have never forgotten the fear it caused in my heart till date. Another part of our rotation was at the University Hospital, literally just across the street. It had affluent patients with private insurance and private attending physicians, where we as residents were not allowed to make decisions without first discussing with the attending physicians. The question for us today is, do they all have the same rights to healthcare? The inmates who intimidated and threatened a young physician with the least of the least privileged ones, and the affluent ones with private attending physicians and private insurance. And this is the core of discussion regarding health equity. Matter of fact, this is the core idea of our great nation, that all lives are of equal worth. One of the 56 founding physicians, actually, who signed the Declaration of Independence was a physician, Dr. Benjamin Rush. But in reality, the problem is we do not live this ideal, and certainly not in healthcare. This is a story of two neighborhoods in our great city of Chicago, Streeterville and Inglewood. They are 30 minutes of drive apart. There's Streeterville, and that's your Inglewood to your right side. There is a five-fold difference in the household median income between Inglewood and Streeterville. And then there is a life expectancy gap of 30 years. So drive 30 minutes, lose 30 years of your life. A great Chicago physician, a health equity champion, and a dear friend, Dr. David Ansel, talks about health inequities and death gap rather elegantly. This is the map of Chicago's transit system, and the pink line is the L train track. If you look at your right-hand side, it's the Loop. Loop is where you all are presently in this great hotel. And the average life expectancy here is 85 years. If you take 7 stops on the L train, you will reach the neighborhood of Garfield, and there the life expectancy on an average is 72 years. Really, it was 7 decades ago that the life expectancy in US was 72 years. So go 7 stops on L train and go back in time 7 decades as far as life expectancy is concerned. Or 7 stops on L train take you from Japan to Bangladesh. This is not just geography. It's also about race. The people of color fare much worse than their white counterparts across many measures of health status. So if you look at this, each column represents a certain race. So among Black Americans, they fare worse than white counterparts on 19 of core measures. Among American Indians, they fare worse on 17 measures of health status. Hispanic among 14 measures of health status, Native Hawaiians among 8, and Asians fare worse than white counterparts on 3 measures of health status. Another way to look at it is the life expectancy of Blacks and whites in the United States. from 1951 to 2010. The blue lines are white and the dark blue is black. One way to look at it is, if you look at the red line that I draw, that in 2010, life expectancy of Black Americans was the same as the life expectancy of white Americans in 30 years. So they are 30 years, 3 decades behind in terms of life expectancy gains between these two races. Well, and it's not just about geography or race. Really, it's about the income levels as well. You would see in this chart the relative risk of all-cause mortality by US household income levels. To your left, you have the all-cause risk mortality relative risk 3 times higher if you have income level of under $25,000 a year. And then it very nicely reduces among different income thresholds. And then if you are above the $115,000 a year, you have a much lower, 3 times less risk of overall mortality. With this background on inequities, let me take you to Humboldt Park Health. We are a 200-bed hospital, safety net hospital, located on the west side of Chicago. We serve a diverse community, as you can see, with Latinx, Black African American, others, with a predominant public insurance payer mix. Almost 80% of our payer mix is Medicaid and Medicare, with Medicaid greater than Medicare. Ours is a story of transformation. I joined this organization in 2012 when I moved here from New York to Chicago. At that time, we were really on the verge of bankruptcy, about to close our doors. This is the ABC 7 news article that Norwegian American Hospital, that was our name at that time, might be closing. And Becker's Hospital Review, which is the sponsoring organization of this conference, wrote an article about us that Norwegian American Hospital in Chicago may close due to Medicaid cuts. However, as Mark Twain would say, reports of my death have been greatly exaggerated. With a great team, we were able to turn around and transform this organization. Over the last 10 years, we have received many accolades and awards, and we are in a pretty good financial health presently. In 2015, we received the Patient Safety Excellence Award from Health Greats. We were featured in Chicago Tribune as a hospital with one of the lowest infection rates. We received a very prestigious Gage Award for Innovation and Excellence for our perinatal care program that showed significant improvement in perinatal morbidity and mortality. And during the pandemic, we received a lot of recognition for a prompt implementation of our telehealth program, which ensured uninterrupted access to care for our disadvantaged communities. We were recognized by the Telehealth Illinois Broadband, as well as by the International Hospital Federation. We also have a vibrant stroke program, which received the Gold Plus Award last year. As this transformation has been underway, we also have changed our leapfrog safety scores from the lowest possible F in 2012, going to C and finally a B, and we are hoping to change this to an A this year. In 2020, of course, the COVID-19 pandemic hit the world. One of the side effects of the pandemic was that it brought the issue of disparities and inequities to the forefront of national dialogue. Why is that? We observed during the pandemic that racial minorities had much higher rate of cases, hospitalization, as well as death. As you would see in cases, American Indians, Black African Americans, Hispanics had at least 1 to 1.6 times greater risk of developing COVID-19. Among hospitalization, again, a 2 to 3 times higher risk of being hospitalized and almost 2 times higher risk of dying from COVID-19. At my own hospital, throughout this pandemic, our COVID-19 positivity rate has been at least twice that of the city of Chicago. So at our hospital, we wanted to be a part of the solution, not just by delivering healthcare as a healthcare provider, but also by providing tangible, concrete solutions to understand and address health disparities and advance health equity. So in January 2021, we took a bold step of changing our name from Norwegian American Hospital to Humboldt Park Health, which really reflected our diverse neighborhood. And more importantly, we created and embraced our tagline of advancing health equity. We were very clear in our mission. We didn't just want to understand the existence of health disparities. We wanted to take concrete actions to mitigate disparities wherever we could find them. So in January 21, we created a health equity committee, which I chair, which actually is part of our governance of the organization and reports to the board. In our committee, we looked at the literature. We drew from the Illinois Hospital Association framework, which talks about focusing efforts on 4 dimensions: our people, which is board and leadership and all employees; our patients, focusing on demographics and profile and health outcomes; or organization, talking about policies and practices and operation; and our community, which talks about community engagement, empowerment, and philanthropy. We also look to IHI framework for inspiration and ideas. It talks about making health equity a strategic priority. It talks about developing structure and processes to support health equity work. And they go in a lot more details about leveraging data and technology to understand and address health disparities. So with these as guiding principles, we created our health equity priorities and framework at Humboldt Park Health. It includes, with the green, aligning staff and organization to health equity. We wanted to make sure everyone, including the board and the physicians, are on board with health equity. We want to create health equity dashboards so that we can understand if there are disparities in health care processes and outcomes. We want to empower patients by providing them access to health information on patient portal in EHR. LGBTQ inclusivity is another important dimension of our work, which I'll discuss later. And extremely importantly, assessment of social determinants of health and addressing social determinants of health along with community partnerships. So this became a focus of our priority over the last 1 year. Why social determinants of health? Let's look at some data to understand the context for social determinants of health. I think you all know already that healthcare expenditures in the United States are significantly higher than those of the developed countries. As you can see in red, you have US spending 17% of the GDP on health. OECD country average is at 8.6%. Not only that, our trajectory of healthcare spending as a percentage of GDP continues to rise. As you can see, we were all in 1980 at about the same level. And over the last several decades, the top line represents US. Our percentage of GDP on healthcare has grown at a significantly greater pace than that of other OECD countries. In spite of spending this kind of money on healthcare, regrettably, we do not get the value for the investment. It's a busy slide, but let me walk you through this. This is an example of how the health status in US ranks among OECDs. So the top line is the infant mortality in the first year of life. US ranks 25 among 29 countries in this particular measure. Maternal mortality, we rank 22 among all countries. Life expectancy from birth, we rank 23. And again, if I look at races on infant mortality, all races 25. But even if we change the data and look at whites only, we still rank 22. So there's something not right with this picture. Another way of looking at our healthcare system performance ranking, this evaluation ranks 11 countries along healthcare system performance. And again, sadly, our overall ranking is actually number 11. Access to care, number 11. Administrative efficiency, number 11. Equity, 12. Number 11. Healthcare outcomes, 11. Care processes, actually, we rank pretty high at number 2. What that tells us is we have excellent technology, well-trained professionals, our care processes are excellent, but there is something about our system inherently that leads to suboptimal outcomes. I believe part of the answer lies in our spend on social services. So this is a graphic of how much each OECD country spends on healthcare and how much on social services. US is here in the middle. Again, on healthcare, the light blue line is the highest, but on the social services, we spend only 9%, which is significantly less than, let's say, France and every other country. Why is this important? If we look at what determines health, you can see 40% is by consumer behaviors, 30% by genomics, which is difficult to change, 20% by socioeconomic and environmental factors, and 10% in direct healthcare. So only 10% of the outcomes are actually determined by direct healthcare. Almost 60%, 40 plus 20, are influenced by social determinants of health. And to your right, you would see the social determinants of health include education, healthcare, neighborhood and built environment, social and community context, and economic instability. So with this background, we wanted to actually do something about social determinants of health as a part of our health equity work. So we incorporated a social determinant of health screening for all our inpatients in our electronic health record, and our social workers screen appropriate patients to see if they have any SDOH vulnerability and if they could be addressed. So this example shows you how we screen for food insecurities in our EHR. This is our preliminary data on our inpatients over the last 5 months. Our social workers assessed 216 total patients for SDOH. 27.8% of 58 patients tested positive for SDOH issues. 40 had transport issues, 2 had physical safety issues, 30 had housing issues, and 19 had food issues. Obviously, the total is greater than 58 because one patient might have more than one SDOH problem. Another part of work has been incorporating equity and inclusivity in our core values statement. So we added these two in our core values, and we are disseminating this throughout the organization and the community. We also wanted to focus the mental health issues, particularly for LGBTQ community. So these are graphs from the Trevor Project from 2021. As you know, it's an extremely important project looking at mental health issues in LGBTQ youth. To your left, you would see by race, unmet mental health care needs by race and ethnicity for LGBTQ youth. Black youth have the highest unmet need, followed by white at 53%. This particular graphic on the right shows barriers to mental health care among LGBTQ youth who wanted it but didn't get it. Biggest problem was they could not afford it. They did not want to have to get the parents' caregivers' permission. They were not out about LGBTQ identity. And finally, the nearest place was far too away. Overall, there was a great limitation in access to care for this particular group. So with this in mind, we started an outpatient behavioral health clinic in June of 2021, it's a multidisciplinary clinic, has evaluation, assessment, substance abuse evaluation, group counseling, family counseling, medication education. We then had all our staff, and they are now LGBTQ sensitivity trained. They each received a 16-hour training, and that has given us the label of an LGBTQ affirming provider. We believe this will provide significantly improve access to care for LGBTQ community in Humboldt Park Health. Let me share with you our data on health disparities. So we looked at 3 key ambulatory measures. Let me start with breast cancer screening. Last year, a total of 607 patients were eligible for screening. This is the racial breakdown of these 607 patients, pretty much reflective of our community. 147 white patients, 158 Black, 247 Hispanics, a handful of Asians, and 36 patient decline. About 25% of the patients, 179, identified Spanish as their preferred language. And these are the stratification of our breast cancer screening data by race and language. In blue is the patients who had the screening done. Red are the patients who did not have the screening done. So for example, 80% of the white patients had the screening, 20% didn't. Among the Black patients, 89% had the screening done, 11% didn't. Among Asians, 84% had the screening, 16 didn't, and Hispanic, 85 and 15. Among the language identification, both groups had identified percentages, 84%. So there was no difference when it came to language as to who gets the screening and who doesn't. This is similar data on 960 patients for cervical cancer screening. Again, breakdown of these 960 by race, reflective of our community, and again, about 25% of the patients identified Spanish as their preferred language. Stratification by race, 54% had screening, red ones didn't. As you can scan across, identical numbers, both for racial stratification as well as language stratification. Similarly, this is diabetes screening with hemoglobin A1C, 729 patients. Racial breakdown reflective of our community, about a fourth identified Spanish as their preferred language. And these are the people who had the screening, blue ones, 57, 58, 39, 56, and 55. And same with the race, the language. Now, one caveat you would think is that these are all measures of care process, not the outcomes. And we are presently looking at the outcome measures, such as, are there any stratification, are there any disparities in the better control of diabetes or better control of hypertension? It is possible that our employees' ethnic makeup is quite reflective of our community. And if that is the case, it turns out to be the case, that would be quite useful, because then that means a diverse workforce would be pretty important to mitigate disparities in a diverse community. Another important project that's underway is a new community wellness center. It's a $25 million community wellness center that is being built, expected to be completed in 2023. It's really a transformative building. We will have an inpatient indoor pool, indoor walking racing track, gym, sports medicine, physical therapy, rehabilitation, nutrition services, all available at a highly affordable cost, both to our community as well as our staff. We're also looking at affordable housing. This data shows that the housing cost burdens across various metros. As you can see in Chicago, to your left, low-income families, almost 50% of the low-income families feel the housing burden. That means they can afford to pay either just the rent or put food on the table or buy prescription medications. To mitigate this, we know that there are 4 pathways connecting housing and health: stability, quality and safety, affordability, and improvement of the neighborhood. These 4 pathways lead to better health outcomes and healthcare cost if you can address the housing situation. With that, we are presently seriously exploring a 40-unit affordable housing right in our neighborhood so that our community can get the benefit of affordable housing as another social determinant of health. Finally, let me share that equity, I believe, is indispensable to quality. And this is not a new concept. For sure, the pandemic brought it to the fore. But if you look at the 6 dimensions of good healthcare and healthcare quality that were published by the Institute of Medicine in 2001, the care should be safe, effective, patient-centered, timely, efficient, and equitable. Healthcare equity has sort of been the forgotten aim of healthcare, and we have to bring it back into the picture. Similarly, this was another report published by IOM, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. So it's about time that we all got together and started to make healthcare work for every single American. I started my story with the famous Kings County Hospital in Brooklyn. Let me close it with another famous county hospital, Cook County Hospital, in our beloved city of Chicago. This is the Louis Pasteur Memorial Plaque at Cook County Hospital. One doesn't ask of one who suffers, what's your country and what's your religion. One merely says, you suffer, this is enough for me. You belong to me and I shall help you. This is the essence of health equity, ladies and gentlemen. Thank you and have a great rest of the meeting.